Hi, my name's Julian. I'm one of the doctors who's been working in the emergency department at Cramlington Hospital. Today I just want to talk a little bit about normal facial anatomy as a sort of precursor talk to my facial trauma talk that you can watch after this. So what we're going to cover today is why is this important to know about, the bones of the face, paranasal sinuses, innervation and vascular supply of the face, and also the normal face in imaging, more specifically X-ray. So why is it important to know about this? Well, I'm not sure about you, but if I were faced, excuse the pun, with something like this, I would be really quite overwhelmed and I would find it difficult to know where even to begin in managing this sort of presentation. So it's clear that the face is a very, very complex structure and we need a sort of certain understanding and approach towards this kind of presentation. It's also a very common presentation to the emergency department. Alcohol-induced injuries, elderly falls, road traffic accidents, assaults can all involve facial injuries. On the extreme end, facial injuries can be absolutely horrendous and can involve airway compromise, massive hemorrhage, intracranial and cervical injury. But also, on the other end of the spectrum, they can really be quite subtle, and facial x-rays are amongst the most misinterpreted x-rays in the emergency department, as shown in a number of different studies. So that's why it's important to understand a bit about this, but let's move on to the bones of the face. So starting off with, this is just an image of, for want of a better word, an exploded skull. And this is just to give you a bit of an impression as to how complex and unintuitive the shapes of the bones of the face are and how many paired bones there are as well. You know, the ethmoid bone, lacrimal bones, these are all paired bones. The frontal bone, the mandible are not paired, nor is the sphenoid bone. But basically, the skull is divided conceptually into two areas, the cranium and the face, or the facial bones. And you can see that here. We have the skull up here, and we have the face down here, and the cranium here. I understand, clinically this is not massively helpful because oftentimes injuries can span across this entire structure of the skull, but it just allows us to orient ourselves a little bit when we're trying to learn about this particular part of the body. So looking at the actual face then, anteriorly the cranium does contribute some of its own bones to the face, as it were. We've got the frontal bone, the parietal bone, and the sphenoid bone right the way back in the sockets of the orbit. The facial bones, you can see there's a number of different facial bones. A lot of them are paired. I'm not going to go through and just list these in a two-dimensional picture because it's actually a three-dimensional structure. So I know that I've mentioned that the frontal bone is a cranial bone, but actually I think it's useful to include it in our taxonomy of the facial structures. Reason being, you have frontal sinuses within this part here, and also the frontal bone does contribute to the superior rim of the orbit. The other thing worth noting is if you were able to basically fly into somebody's cranium like this, you'd find a very important structure residing in here, which would be your brain. So it's just worth noting that the only thing sort of standing between your brain and the outside environment is your face and your frontal bone, at least anteriorly speaking. So that's just worth mentioning. So that's the frontal bone, which is basically your forehead. Now if we follow this down laterally, we come to quite a interesting bone called the zygoma, or the zygomatic bone. Now this bone can be thought of as sort of a four-legged stool, and I'll show you over here like a bar stool down here. Reason being, it's got four basically connecting parts to the different bits of the face and the skull. If we look here, we're looking at a sort of anterolateral view of the face. This is the zygomatic bone. Leg 1 is the zygomatic arch. Leg 2, the frontal process that connects the zygoma to the frontal bone. Leg 3 is sort of the lateral inferior wall of the orbit, and leg 4 is the maxillary process that connects the zygoma to the maxilla. Just to show you that in a 3D orientation, as we see here, we've got the zygomatic arch coming across here, connecting to the temporal bone, and then leg number 2, we've got the frontal process with a little suture here connecting to the frontal bone. Leg number 3, we've got the lateral wall, or with a bit of inferior part of the wall of the orbit. And leg number 4 is the maxillary process that connects the zygoma down to the maxilla. You can have fractures across any of these different legs, and even if all of them are fractured, like in a tripod fracture, the zygoma might sort of dissociate from the rest of the skull. So if we're following this zygomatic bone down, we come onto this bone. Now, this is known as the maxilla or the maxillary bone. This and the zygomatic bone are referred collectively as the midface. And we can see that the maxillary bone is the largest bone of the midface. Now, this can be involved in trauma very much, and what we have here is a little fossa called the infraorbital fossa, where the infraorbital nerve comes from. This is a branch of the V2 or the maxillary branch of the trigeminal nerve, and this infraorbital nerve supplies sensation to the inferior parts of the, like below the eye, the lateral part of the nose, basically this area here. So that can be damaged in facial trauma. The other important thing to note about the maxillary bone is that it forms the inferior floor of the orbit. Now, if you experience something called a blowout fracture, which is basically when you have a acute increase in the intraorbital pressure, usually as a result of a blow to the eye, the weakest part of all of this structure in here, the weakest wall, is the inferior floor, this maxillary part here. And what can happen is you can basically sustain a fracture that kind of results in almost a trapdoor that opens up, and contents of the orbit, such as the periorbital fat, the bits of soft tissue, and even the inferior rectus muscle, can be tethered through that fracture and can present in different ways that we will talk about in the facial trauma discussion. So that's we've covered the frontal bone, the zygoma, the maxilla, and now we're going to look around the orbit a bit further. So just quickly worth noting, you can see here is where the optic nerve will come from. But starting posteriorly, we've got the sphenoid bone, which is this big, weird, complex-looking bone that sits right between the cranium and the face. Moving forwards, moving anteriorly from the sphenoid bone, we have a paired bone called the ethmoid bone here. And this is part of the medial wall of the orbit. That goes on to the lacrimal bone here, which is quite an easy bone to remember, because you just remember you've got your lacrimal duct here, which basically transports tears to the outside world. So this is all part of the medial wall of the orbit. We've already covered the maxilla here. So the next one is the nasal bone. And this is basically just a sort of superior projection of bone, the superior part of your nose. The rest here would be made up of cartilage. And if we're on the topic of the nose, let's have a little look inside the nose. So we've got the nasal cavity inside here, and I'm just going to focus a little bit on the septum. So the septum is a sort of a vertical wall that divides the nasal cavity into the left and right sides. The structures that contribute to the septum are this particular one here, which is part of the ethmoid bone, and this is the superior anterior part of the septum. Slightly further back here, we've got the vomer, and that contributes to the sort of posterior inferior part of the septum. And you'll notice we've got a bit of a hole here. What contributes there? Well, if we go to a different picture, this is sort of looking side on, if you will, like a cross section. You can see this is our septum. We've got our ethmoid bone and our vomer, as mentioned previously. Filling in that gap, we have septal cartilage. You'll also see why it's pretty useless if you have a nosebleed to pinch the top part of your nose, because that is just pure bone. You can't really compress the bone very well. Therefore, if you're experiencing epistaxis or nasal bleeding, you should pinch the lower part over this soft cartilaginous area, particularly where Little's area is, which we will come on to in a short while. So, what have we covered so far? We've covered the frontal bone up here. This guy here, we've covered the zygoma, we've covered the maxilla, we've also covered the sphenoid bone back here, the ethmoid bone, the lacrimal bone, the nasal bone. We've gone over the septum involving the vomer and the ethmoid bone. Now the last one remaining really is the mandible or the lower jaw. So the mandible is connected to the skull via the temporomandibular joint. You've got the mandibular condyle in there, and you've got the coronoid process up here as well. So the condyle of the mandible in the temporomandibular joint can actually dislocate either anteriorly, posteriorly, sometimes even superiorly, depending on the transmission of force. You'll also notice this little fossa here. Goodness me, that was quite close. That is the mental fossa, and the mental nerve comes out of there. It's another small branch of the V3, or the mandibular branch of the trigeminal nerve, and that provides innervation to this part of your face. Okay, so that's just a bit of an outline of all the bones of the face. Now let's move on to the paranasal sinuses. And what exactly are the paranasal sinuses? Well, they are sort of pockets of air within certain bones that develop through our childhood and adolescence as continuations from the nasal cavity. So they continue on from the nasal cavity and provide these pockets of air within the surrounding bony structures. The paranasal sinuses are lined with epithelium. They have goblet cells that drain mucus from the paranasal sinuses into the nasal cavity. And in terms of their function, there's no kind of hard and fast answer about what their function is, but theories that have been put forward are that it helps lighten the skull itself, it helps with vocal resonance, there may be some sort of immune function involved as well. But all being said, there's basically 4 paired paranasal sinuses. We've got up here the frontal sinuses, the ethmoidal sinuses, the maxillary sinuses, and the sphenoidal sinuses. Easy to remember because they're just related to the bones that they lie within. So they're air-filled pockets. And with regards to sinusitis, this is something where there's inflammation within the epithelium and the actual sinus itself. So, for example, if you've got an upper respiratory tract infection, that may track upwards into, most commonly, I believe, the maxillary sinuses. You might even get a fluid level in there if it's a nasty enough infection. And if you press on this area on someone's face who's experiencing sinusitis, it should be quite sore. So those are paranasal sinuses. Next, innervation. Now, there are 2 primary nerves that we're going to concern ourselves with regarding innervation of the face. That's the trigeminal nerve, and broadly, that provides sensory innervation of the face, and the facial nerve, which broadly provides motor innervation of the face. So let's have a look at the trigeminal nerve to begin with. We just have to leave our friend here and find our friend trigeminal nerve. So this is the trigeminal nerve, and you can see the temporal bone has become transparent. We can see the trigeminal ganglion just here with lots of different branches coming off it. And the trigeminal nerve provides sensation of the face. So there are 3 primary branches of the trigeminal nerve that provide sensation of the face. The first one that provides sensation to the upper portion of the face is the ophthalmic or V1 branch. The next one that provides sensation to the mid part of the face is the maxillary or V2 branch. And the third one that provides sensation to the lower part of the face is the mandibular or V3 branch. So it's important to say that the trigeminal nerve doesn't just provide sensation of the face, but it also provides innervation to the muscles of chewing and mastication. Specifically, it's the mandibular branch, or V3, that provides innervation to the temporalis muscle, the masseter muscles, the lateral and medial pterygoid muscles, and these all allow us to chew and do basically mastication. Okay, so another thing to say is the trigeminal nerve provides sensation to the anterior 2/3 of the tongue, whereas the facial nerve provides taste of the anterior 2/3 of the tongue. And finally, the trigeminal nerve provides the afferent part of the corneal reflex, which is the sensation of the cotton wool on your cornea, and that feeds back into the brainstem and is the sensory part of that reflex. And if you're interested in sitting the FRChem primary, or you just want to know more, these are the sub-branches of V1, V2 and V3, or the ophthalmic, maxillary and mandibular nerves. So it's worth learning these if you're interested in that. And as I mentioned before, the infraorbital nerve that comes out through the maxillary bone and provides sensation to this general part of the face. So that is the trigeminal nerve. we're moving on to the facial nerve now. So let's have a look at that. We leave our friend here and we go to the facial nerve. So the facial nerve is a nerve with a very complex tortuous course, and all we're going to focus on today is the extracranial portion of the facial nerve. So you can see it's coming out of this little hole here called the stylomastoid foramen, which is a little foramen that resides just behind the mandible. And, you know, if there's a dislocation, a posterior dislocation that's severe enough, or any other type of trauma to the side of the face, there is definitely the possibility of a facial nerve palsy affecting the muscles of that side of the face to varying degrees. And so the facial nerve provides innervation to the muscles of expression, facial expression. And just like the trigeminal nerve, there are a number of different branches. There are, in fact, 5 branches. So working our way from superior to inferior with the different branches, we have the temporal branch, because it goes over around the temporal area where the temporal artery is. The zygomatic branch over near the zygoma. The buccal branch, these 2 small branches here. The mandibular branch over around the mandible. And then we have the cervical branch that is basically located around the cervical area. And these innervate all of these muscles of facial expression, like orbicularis oculi, which helps close the eye. The muscles to make you smile, laugh, grimace, all those different muscles. And as I mentioned, it innervates orbicularis oculi, and that is the efferent part of the corneal reflex. So that allows us to blink. So we get the sensation via the trigeminal nerve of the cotton wool on our cornea, goes back to the brainstem, and then the efferent part of that is supplied by the facial nerve and allows us to blink and hopefully end the unpleasant feeling of the cotton wool on our cornea. Now, this is a handy way to just remember those different branches of the facial nerve. So that's innervation. Now, just a little bit about vascular supply. Main thing to note is that the face is an extremely vascular structure. There's a lot of anastomotic areas, and if you're unlucky, you can have a significant amount of bleeding from facial trauma. So fortunately, the Royal College of Emergency Medicine doesn't need us to learn a huge amount of arteries, but the 2 main ones that it does want us to know about are the facial artery and the superficial temporal artery. These are both branches from the external carotid artery. The reason we should know about these is because they basically contribute the perhaps biggest vascular supply to the whole area of the face, the anterior part of the skull. And any disruption of these 2 arteries can result in significant bleeding. So just worth knowing about those. Facial artery has a lot of anastomoses around it. Superficial temporal artery, where you have your temporal arteritis potentially, is superior to that. It's also worth saying something about the nasal arterial supply. So, as I mentioned before, if you have a nosebleed, you want to squeeze on this cartilaginous part of your nose, and this part just so happens to house a small area called Little's area. Sounds very benign, but in fact it can be a real pest if it is disrupted. The reason for that is it is an anastomotic region that anastomoses a lot of different arteries, including the ethmoidal arteries, sphenopalatine artery, greater palatine artery, and the superior labial artery. So all of these anastomose in this area called Little's area, and so that can, if that's disrupted, you can have septal hematoma, you can have a lot of bleeding from epistaxis. Basically, it can be a pain. So just something to bear in mind there. All right, so that's pretty much the kind of basic anatomy that we're going to cover today about the face. Now we're going to look at some views of x-rays. So when you're requesting x-rays of the face to check for fractures, these are probably, well, all of these in fact will be your standard views that you'll be asking for. The most standard view, which gives you probably the most bang for buck, is the occipitomental view, the OM view, otherwise known as the Waters view. Now this is excellent for visualizing the upper and middle thirds of the face. Reason being is we ask the patient to caudally tilt their heads, i.e. Sort of tilt their head backwards. And what this does is it gets the posterior part of the skull, this bit of cranium here, out of the way so that it's not overlapping with all of the facial structures that we're going to want to look at. And what you end up with is a view something like this. So we can see here that it looks like the patient has tipped their head back a bit helpfully for us. And so we can see that we've got the frontal bone up here, we've got the frontal sinuses here, superior margin or the superior rim of the orbit. And then following down, we've got the the frontal process of the zygoma. The zygoma itself, we've got the maxillary process around here, zygomatic arch around here, and then the part of the zygoma that contributes to the latero-inferior orbital floor. We've got the sort of nasal septum, which is sort of visible here, and we've got the maxilla, that bone, the biggest mid-face bone around here, and we can see that much of the maxilla actually is just air-filled because of those maxillary sinuses. So that's a OM view, and perhaps a slightly better one here that helps us really visualize the zygoma is this view, slightly further tilted back. And we can see this is the body of the zygoma, zygomatic arch coming back here. We've got the maxilla coming over here, and we've got, the midline coming down here, which basically passes through the nasal septum. And we can see also the mandible, the outline of the mandible down here. Got mastoid air cells over here. That's what these funny looking things are. And that's just some sort of similar paranasal, in a similar way to the paranasal sinuses, some air-filled pockets around these parts of the face. Now, that's the OM view. You can also request a 30-degree OM view. And this allows us to see the zygoma and the maxilla slightly better. And what this does is, instead of having this X-ray horizontally oriented, it superiorly angulates the X-ray about 30 degrees, and that results in an image like this, which basically appears as if the patient has tilted their head back even further. And as you can see, the maxilla and the zygoma are both very, very well visualized. The frontal bone has sort of disappeared out of shot, but we can still see the frontal sinuses, we can still see the orbits to a degree. The nose is tilted right up, we're looking right up this person's nose. But the zygomatic bones are visualized extremely well. We can see the coronoid process of the mandible here, and the condyle is going to be somewhere over here, connecting with the temporomandibular joint. But basically this just allows us to get a really good view of the zygomatic and maxillary bones. Standard views also include a lateral view that you can request. You can see the frontal sinus, a little bit of nasal bone here, the maxilla is over here, largely just consisting of air-filled sinus here. You've got your mandible coming up here, the angle of the mandible and the ramus. Here's the mandibular condyle sitting nicely in the TMJ. And, this is an X-ray that you can request as well to just triangulate your views. Now, the Caldwell view is basically the opposite of the Waters view. Instead of tilting the head back, we're tilting it forwards. And this is going to push our frontal bone and our frontal sinuses further into view. So this is really the view you want if you want to emphasize that frontal part of the skull. You can see your frontal sinuses very clearly here, the frontal bone as well. You might see some fractures running through there. The orbits are quite well visualized, as are the superior and lateral parts of the zygoma. But apart from that, there's not a great deal to see because everything's superimposed on top of each other and you can't really make out a great deal. Again, we've got those mastoid air cells over here as well. Finally, we've got the OPG, or the orthopantomogram. This is an excellent X-ray for visualizing any obvious mandibular fractures or helping you discern any mandibular dislocations. So what this is basically is like a panoramic view of your mandible, taken sort of as a 180-degree sweeping arc around the mandible and then unrolled in a 2D image. Now, the downside about this type of X-ray is that because of the way it's taken, there can be superimposition and overlapping of some of the bony structures, meaning that it's not the most diagnostic image to have, but it definitely should be able to help pick up obvious fractures of a mandible. You can see down here we've got the hyoid bones, we've got the mandible itself, so we've got the body of the mandible over here, angle over here, the ramus up here, the coronoid process over here, and then you've got the condyle of the mandible up here, you've also got it up here, and it's sitting nicely in the temporomandibular joint. If this condyle was over here, it might mean that you've got an anterior dislocation, for example. So you can also see a bit of maxilla, but you can appreciate why this is not the best view for your maxilla. But essentially, it's going to help you look at the mandible, the mandibular condyles, and just see are there any fractures or obvious dislocations of the mandible. Right, that was a bit of a whistle-stop tour. I really hope that was useful, and do make sure you check out the facial trauma talk after this. Thanks very much.